Welcome to Kaiser Foundation Hospital in Fontana, California. Over the next hour, see treatment for an abdominal aortic aneurysm featuring the Gore Excluder AAA endoprosthesis. If a rupture of an abdominal aortic aneurysm occurs, the person experiences severe pain in the back and/or abdomen and may become unconscious. Unless the leaking aneurysm is surgically repaired immediately, death results. In just moments, you'll see how the Gore Excluder AAA endoprosthesis is used to internally reline the abdominal aorta and isolate the aneurysm from blood circulation. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed medical care. Now, let's go live to the operating room.
Hi, my name is Dr. Jeffrey Hsu, a vascular surgeon here at Kaiser Permanente Fontana in California. I'd like to welcome everyone to our webcast where we will be demonstrating today an endovascular abdominal aortic aneurysm repair, highlighting the percutaneous approach as well as the use of intravascular ultrasound. At this time, I would like to introduce my partners, and so Dr. Vo, let's go to the operating room, and let's introduce the members of our team.
Welcome to Kaiser Fontana OR Live. Today, we're performing an endovascular abdominal aortic aneurysm repair using the Gore Excluder endoprosthesis. This requires a dedicated team effort, and I'd like to introduce my partners, Dr. Paul Aka, Dr. Majid Tayara, our always dependable radiology technician, Gary, our lovely surgical technician, Gigi, and of course our circulating nurse, Becky, and Bung Parks over there. Bung is the type of person who always seems to know what we need before we know it. And behind the curtains is our anesthesia team, Dr. Curlin, and our two anesthesia assistants, Jeremy and Tara. Sorry about that. And actually, the most important member of our team is the patient. Richard, are you comfortable? Great. As you can see, the patient is awake. We prefer to do most of our procedures under spinal, epidural, or sometimes even local anesthesia. Let's focus in on the left groin. We have already percutaneously punctured the left common femoral artery. Can I see the introducer needle? We have already percutaneously punctured the artery, and then we applied 2 ProGlide sutures, one on each side without securing them. We punctured under ultrasound guidance to make sure that the artery is free of any calcified plaques and to make sure we're well above the femoral bifurcation. My partner, Dr. Chiara, will now demonstrate this procedure on the right groin.
Okay. So Dr. Aka is holding pressure while I remove a 5 French sheath. And I'll have the 8 French dilator, please. So with this approach, the artery does not need to be dissected out, and instead we place 2 sutures right into the artery that we tie at the end of the procedure. Okay, relax. Okay, pressure.
Now we'll take the ProGlide.
Now we're going to put in the first suture. And we place these sutures when the puncture in the artery is small, and then we dilate the artery so that we can place the device inside the artery. And then at the end, after it's dilated, then we tie down the sutures. So the first suture is going in. Okay, wire out. Okay, relax on the okay. And the 2 sutures are placed, one at 15 degrees medial. cut the suture there. Wire, please. And this device works by opening up a foot plate inside the artery, and then 2 needles come from outside the artery and suture through the artery. Okay, hold pressure. Okay, next ProGlide. So now we'll put in the next suture. This one was placed slightly medial at about 2 o'clock, and this next suture will be placed at about 10 o'clock. And that way, when the sutures are tied, the artery does not get narrowed. Okay, wire out. And again, I know I'm in the artery when I see blood flow. Now I'm against the inside of the artery, and I fire the sutures. And we're going to cut the suture here, needle back, take the foot plate down, pull the device out, and here's the suture. And we're not going to tie it until the end of the procedure. Okay, Benson wire. Thank you. Okay, I'll take the 8 French sheath next. Okay, Flora?
Why don't we put the glide catheter, and then you can get your wire all the way up there, and we'll exchange for the stiff wire. Glide catheter?
Off, Flora.
Let's take this out and put a glide catheter in.
No. 8 French sheath, please. Hold pressure. No. Yeah, I can't get through because there's a...
That's why you need the glide. Oh, you didn't fire it?
Yeah, 8 French sheath.
Put the glide catheter so you can direct the wire across it.
I will. Yep, that next. Okay. Okay, so relax.
Let's get the ground around.
All right.
Yeah.
So this wire is too floppy to allow us to dilate the artery up, so we're going to have to put in a stiffer wire, which is what we're doing now. And you can go to fluoro. Okay, fluoro on. And as you can see, the wire is curled up here in the iliac artery. We at fluoro, and we're going to get the wire up into the aorta, which it just went up into the aorta. This is a catheter going up into the aortic aneurysm, and now we're up beyond the aortic aneurysm. Okay, off fluoro. Now follow me up into. Actually, that's okay. Fluoro on. Going to get the catheter up. Now we're going to switch to the stiff wire. Off fluoro.
Let's put our wire up at the arch.
Let me just. Okay, now this is the stiff wire, and we're going to dilate the femoral artery over this wire, but we have to get this wire up into the aortic arch. Fluoro. Go to fluoro, please.
And come
fluoro.
up on the chest.
Follow. Yep. Follow me up, please. Excellent. And there's our wire going up the aorta. There it is up into the aortic arch, which is where we want it. Off fluoro. Okay. You can come back down to the right groin. Okay.
Yeah.
Now. Okay. So we're going to put these sutures away here until the end of the case. And now we have our 8 French sheath and our stiff wire. And we're going to go ahead and dilate up the artery and put in our large sheath through which the device will go into the aneurysm. Bring the fluoro down a little bit, Linda, please. Fluoro on.
Let's get the sheath up.
Okay, that's perfect. Okay. Okay.
You have a 12.
So we're going to serially dilate this artery. We won't put the largest one in first. We'll go with a slightly bigger size than that. This is a 12 French which is about 4 millimeters in diameter. Okay, relax. Okay. And then we're going to go with a 16 French, which is a little more than 5 millimeters in diameter.
No, the 20 French spoon.
Okay, relax. Okay, good. And then finally, we'll go with a 20 French, which is our sheath is just a little bit bigger than this, so if this goes through, then our device sheath should go through. Do this under guidance. Fluoroscopy, please. So, go to fluoro. Now you can see the sheath up into the aorta. There it goes. And it's gone up, well, off fluoro. Okay. And 18 French sheath ready? Okay. And now we're going to place our 18 French sheath. Okay.
The reason we use the serial tapered 20 French dilator is because on the CT there was significant calcifications at the common iliac artery. So we wanted to make sure that passed before we advanced the 18 French sheath.
Okay, fluoro, please. Now we're going to, Dr. Aka is going to advance the sheath.
Okay, fluoro on, please.
Got the wire again?
Okay.
So the most important part of these procedures is to make sure your wire never moves.
Okay.
That's perfect there.
All right there.
Okay. I got sheath, pull dilator out.
Let me get the gloves.
Nice job.
Let's go to Dr. Shu.
No, actually, what we're going to do right now is go to the IVUS. Can I see the IVUS? What we're looking on the IVUS is the left renal vein. And as I pull down, can you hold my sheath for me?
Sure.
Gary, can I see? As we pull down, we'll be able to localize our renal arteries. And that's the left and the right renal arteries coming off. So I'll do that again. That's the renal vein, the right renal artery, and the left renal artery coming off at about 8 and 4 o'clock. And can you show measurements of the proximal neck? So we've already measured what the size of the neck is, and we use the ultrasound, the intravascular ultrasound, to confirm our CT measurements of the diameter and of the lengths. That way we minimize the contrast we have to use and minimize the radiation exposure. Now I'm going to exchange this for a pigtail catheter. We can go to Dr. Shu now while we get ready to do our initial angio run to localize the renal arteries.
Dave, the other person you didn't introduce, Ann.
What I'd like to do is just show a graphic depiction of the ProGlide suture that they had just placed in the operating room, just to clarify, what was actually done. I don't know if this is showing or not.
Are you magged up, Linda? Are you magged
It's a slide showing. Okay. This is the picture of how the ProGlide device is inserted into the artery.
Okay, I got it.
I think the important pictures to focus on are these inset pictures here, where they demonstrate that their two needles come from outside the artery, puncture the arterial wall, and hook up with two cuffs that are attached to sutures that are inside the artery at that time. Those sutures are then pulled outside of the artery. And the nut.
Good. Push forward a few knots. So what we're going to do next is we're going to do the angiogram, and then make sure you're up here so you can be positioned to deploy the graft. Put on clean gloves so you can advance the graft up
clean
first.
gloves on.
Okay. No, Gary, so he can advance it up for you so you don't have to go all the way down.
Okay, go ahead and we should put the graft up, right? So we shoot the angiogram with the graft in place? Go ahead, Paul.
Okay. All right, give me the...
Actually, they
Should we
should
show
probably
that?
see that. They should see that. Just have it ready to hand to us. have clean gloves on. Hey, Jeff, we're ready to, oh, are we on 20 for 10, Bob? Okay. Let's go ahead and focus in on the mag up one, Linda. And center on the piggy a little bit more.
Should I be hearing
Good.
Dr.
Perfect.
Shu talk? Because I was
think
hearing
it's high. It
Dr.
must
Shu
be higher
talk,
up.
but now I can't hear him talk.
No, don't move it. We said it was at 12 and 13.
Yeah, but that's 15 there.
Oh, is he showing a video
Yeah, we
or
said it was
something?
at 12, didn't we?
Yeah, but that's 20. The lower one is 20 there.
Well, I mean,
It was 20, 15, so it's actually higher.
no, it's there. It's there because
Okay.
the ibis was right here and the sheep was right there.
All right.
Yeah. Okay, well, hey, Jeff, we're going to do the initial run. Richard?
I don't know if Jeff's hearing. I don't
Are
think
we
we're
live? We can go back to OR. Are we live?
No.
Do you want the device up first?
No, it's right there. Are we on? Or
I
is
don't
Jeff
think
on?
so. I can't. I lost.
Okay, so we're
We're
ready to
on.
do our initial angiogram, which will localize the location of the renal arteries. The patient's going to help us in this procedure, actually. Richard? Let's go to subtraction. No. Okay, listen to my voice.
Step down that way. Just
Take a
get
deep
ready.
breath in. Breathe out. Take a small breath in. Hold your breath. Don't breathe. Don't move. Don't breathe. Don't move. Inject. Relax and breathe. Okay, so we're going to advance the catheter up to see the renal arteries. Flow on. Flow on. Check this out. Flow on. Let's go up a little bit higher, Linda.
Very good.
Okay, let's do the same injection.
Okay.
Okay, Richard, take a breath in, blow out, take a breath in, hold your breath, don't breathe, don't move. Don't breathe, don't move. Inject. Perfect.
Okay,
Off.
You can breathe, Richard.
So what we're going to do is we're going to mark the location of the renal arteries on the screen. And then we're going to advance the graph slightly, and then we're going to do another run to get a better image of the renal arteries. The left one right there.
Ready with the graph? Remember the orientation.
So Dr. Aka will now have the graph, and he put on sterile gloves so that the graph is actually handled. So we want to make sure we have clean gloves and total sterile techniques. You have to remove the yellow. Flow on for a second, Linda. Good. Bong, on the next injection, can you go 20 for 20? Yeah.
Got the wire? All right.
Now, we're advancing the graft into the sheath.
All right.
I got wire.
So we'll advance this device here slowly.
Demag, Linda.
And fluoro, well, go ahead and put the fluoro on. Okay, here we
Watch
go.
your orientation. Okay, you're good. Hold on one second.
That's good. That's perfect. That's perfect. That's good.
Now,
You probably can't see on the screen, but we did mark out the renal arteries. Now let's mag up again.
did we mark them under mag or under
Oh,
You lose the marking.
fluoro?
yeah, no, we're going to do another run. Let's mag up. You're magged up. Let's see where we are, Linda. Perfect. Now let's do another injection, and we'll get ready to deploy after this injection. Richard, take a breath in, blow out. Take a breath in. Hold your breath. Don't breathe. Don't move. Don't breathe. Don't move. Inject.
Perfect.
Perfect. Off. As you can see, we have a fairly long neck, approximately 3 to 4 centimeters, but there's a bulge in the middle.
Remote control.
So we're going to have more than adequate neck length coverage.
So stay on fluoro for a second. So as you can see, the graft is just below, no, off fluoro. Off fluoro. Okay, go to fluoro. So as you can see, the graft is just below the left. Don't fluoro, please. No. So as you can see, the graft is just below the left renal artery, and we're getting ready to deploy it. Okay.
You ready?
So.
Position it. Come down here.
Yep.
Yeah. All right, so we'll pull back the sheet so the graft can open up.
Okay.
Now it's very important to stabilize everything as we pull the graft.
How's the blood pressure?
Let's pull the blood. What's the mean arterial pressure? 75. Can we bring it down to around 65?
You want your pigtail in the aneurysm?
Yeah. We'll pull our pigtail down. Floor on, please. Thank you, Pat. While we have a little time, I'd like to introduce Linda. She's our radiology technician also. Also Ann Crutchfield from Volcano, the intravascular ultrasound. And of course our Gore reps, Pat Reed and Art Hernandez, who's right here.
Dave, do you think it's a little high?
Yeah, it is. I mean, we have a long neck, so we should err on lower, not higher.
Fluoro?
Okay. Lower. Lower. We have a very long neck. Good.
Okay.
We are error. Okay, good. Ready?
Okay.
How's the pressure doing?
So what we're doing is we're lowering the mean arterial pressure. It's what the device manufacturer recommends so that there's less aortic pulsation that can push the graft down. And usually I think they're recommended at mean arterial pressure around 65. We can go to Jeff while we're waiting for the pressure to come down.
What I'd like to do now is I'd like to go over some of the general aspects of the disease, abdominal aortic aneurysms. We realize that there may be some potential patients out there watching this. An aneurysm is commonly defined as an abnormal enlargement of the artery, usually due to an injury or weakness in the arterial wall. It is commonly defined as an increase of the diameter of the artery about 1.5 times its normal diameter. Pictured here is a 3D reconstruction from a CT scan showing an abdominal aneurysm, and you can see the aorta comes down, gets large below the renal arteries, and branches off into the two legs. The incidence of this problem has been increasing, essentially tripling over the last 30 years. Approximately 1.5 million people in the United States have an abdominal aortic aneurysm, and there is a male predominance of approximately 4-to-1. The risk of having an abdominal aneurysm is that it may rupture. It is the 13th leading cause of death in the United States. This is another picture of an aneurysm. This is an infrarenal aneurysm. Most abdominal aortic aneurysms are in fact infrarenal, and they are also associated with, often associated with other aneurysms in other locations. They are also associated with hypertension and smoking. This is a picture showing the relative frequencies of the various kinds of aneurysms that can occur in the aorta. They can occur in the chest or the abdomen or in any of those combinations. The one that we are depicting here today is the most common infrarenal type of aneurysm, this one right here, which has a relative frequency of 63%. Most people with an abdominal aortic aneurysm are asymptomatic. Many of these are picked up incidentally on cross-sectional imaging or ultrasounds for other reasons. Approximately 40% of patients that do go on to rupture will die prior to making it to the hospital. And only 10 to 25% of individuals will survive throughout the hospital discharge if they do make it to the hospital. There are several risk factors with abdominal aortic aneurysms. Certainly, smoking is a risk factor. Family history is a risk factor. Age over 60. And as mentioned before, there is a male dominance to this. So being male is also a risk factor. Other risk factors include hypertension and coronary artery disease. What I'd like to do now is talk about the various ways to manage abdominal aortic aneurysms. We manage abdominal aortic aneurysms based on a risk-benefit ratio, the risk being rupturing. And so we have to have an idea of what the risk is, and we do that based on the diameter of the aneurysm. So I'd like to show a graph here. This comes up. This is a bar graph demonstrating the various risks of aneurysm rupture based on the diameter. As you can see, there is a huge jump from aneurysms in the 4 to 5 range versus the 5 to 6 range of almost a factor of 10 here. And then again, once you reach the 6 centimeter range, it essentially more than doubles after that. So as a result of this, we generally like to fix aneurysms in the 5 to 6 centimeter range. 5.5 centimeters is the accepted standard. I'd like to right now cut back to the operating room. I think Dr. Vo is now ready to deploy the graft.
Welcome back to the operating room. Our anesthesia team has effectively lowered the mean arterial pressure to 65. Dr. Aka will now demonstrate deployment of the graft.
So this is the simple device. It's like a ripcord that will release the graft.
Fluoronic for us, Linda?
So anyway, we'll loosen this.
Yeah, we are.
Okay.
He's just loosening.
We'll loosen this. Okay. So ready to fluoros on?
I think that's perfect.
So we'll go ahead and pull this string. And it's kind of hard to see on the fluoro, but the graft has been deployed.
So go to fluoroscopy.
And now
You can see the graft is now.
Dr. Terra will be advancing a balloon to secure the stent.
You know, we had a long neck, so we weren't trying to just place the graft exactly at the renals. But when you have a short neck, it's very important to place it right at the renal arteries. And in that case, we would probably do a slow deployment with the gore excluder graft. But in this case, the neck was approximately 3 to 4 centimeters, so we had plenty of room. No wire.
Now we're advancing a compliant balloon
Let's go to fluoro.
fluoroscopy, which will gently mold the neck of the graft so that the hooks engage.
Off fluoro.
Contrast. So that the hooks that are on the graft engage into the aortic wall. Okay, go to the fluoroscopy, please. Okay, fluoro on. And now I'm going to start gently ballooning. And you can see the balloon. I'm going to take the balloon down. Fluoro on. We're going to balloon one more time. And take the balloon down.
That's perfect.
Now we're going to go ahead and take out, we're going to hold the sheath, please. Thank you. Now we're going to go ahead and take out the balloon, and we are going to access the contralateral gate, which allows us to complete the repair by lining both the left iliac artery and the right iliac artery with the stent graft.
Yeah. No, demag it.
Moist blue towel, please.
They actually knocked up one. Mag up one, Linda. Okay. Let's go to the fluoro live. what you see is the pigtail catheter right by that contralateral gate. Let me have the glide wire, please, off fluoro. We're going to use a hydrophilic wire to access that contralateral gate. We have to take this pigtail catheter out. Hold the sheet for me. Sometimes if the pig catheter tail wants to go in the gate, we'll take it. Flow on. So I'll take a glide catheter. You have a hemostat? Fluoron.
So please go to fluoro so you can see Dr. Vo with the wire trying to go through that. It looks like it's actually a circle, but because of the orientation, the way we're looking at it, it looks kind of like an ellipse, and I think he just may have gone through it. So it's kind of like a hula hoop, and you're trying to get the wire through it.
Okay,
you're outside.
That looked promising, but majority of the time it doesn't work. So we'll actually need a more selective catheter with low angulation to it. And this wire gets very sticky if you don't keep it wet. Advance that up. And Dr. Aka will guide the catheter, and I'll try to steer the wire for him. A little bit.
There you go.
I think we got...
No.
No.
That's your catheter. There you go. A little bit more. There you go. Okay. That might be it. Yep. I think that's it.
Off fluoro, DMAG.
Dave, can you hear me?
Yes, Jeff.
Oh, okay. I was just
DMAG.
would now be a
Advance
good
the glide
time
catheter
to
up, Paul.
answer some questions or.
So I think we're inside the graph, but it's always good to confirm it. Go.
The wire is curled up.
Dave?
Yes.
Go up to
Dave.
the chest.
Yes, I can hear you, Jeff. Okay, we'll take the stiff wire now.
Just was wondering whether they could answer some questions up there.
Oh, sure. Go ahead.
You want to cut? Go ahead, Jeff, if you like to.
Okay. Can you guys hear me?
Yes.
Over there? Okay. What I wanted to do was first remind everyone watching that feel free to email in your questions. I have a few of them here, and I'll do my best throughout the broadcast to cover them as best I can. I have one question here. What has been your success rate with doing it percutaneously versus open? We've actually reviewed this, and we have done approximately 69 endovascular repairs using the percutaneous approach since the latter half of 2005. Now, unfortunately, I can't really compare that to open cut downs very well because we started, I got here around that time. When we started doing the endovascular repairs, we pretty much started immediately doing percutaneous repairs. So I really don't have a lot of femoral cut downs to compare them to. But what I can say is that of those 69 endografts that we put in, approximately 128 groins were punctured percutaneously. And we had to convert 8% of those punctures to open cut downs at the time, at the end of the case, most of the time for lack of adequate hemostasis. 8% conversion to open femoral cut down. In terms of later complications or problems recognized in the recovery room or thereafter, we had to take back one patient, which is less than 1% of the groins punctured. We had to take that patient back to the operating room for what was essentially an occluded femoral artery. What had happened in that case was that the foot of the ProGlide had caught the posterior plaque in the femoral artery. When the sutures were deployed, it essentially brought the posterior plaque and sutured it to the anterior wall of the artery, effectively shutting down the artery. We had to open that groin and perform a patch repair. So that's hopefully answers that question. Unfortunately, I don't have the open data to compare that to. Next question here, if a patient has tortuous iliacs, what device do you choose and why? Okay, should we? Okay, I think we should be going back to the operating room. I'll try to answer this question when we return. Dr. Vo, Dr. Tejera?
Actually, we're back. Let's go to the intravascular ultrasound screen.
IVUS.
We have think we went into the graft, so we're going to confirm it using the IVUS. And what you see here is the two renal arteries coming off. Then now you see the hyperdense region of the graft. So we're actually in the graft, not behind it, not in front of it. What you see now is the aneurysm itself, and we're outside the graft. So what we're going to do is we're going to pull down into the iliac artery and find our hypogastric internal iliac artery. And there it is. Flow on and off. Let's mark that out. Let's pull this IVUS out. We're going to advance a pigtail catheter to determine that length so that we can determine what length of limb to place in. Basically, we place the main body that goes into the right leg, and now we have to connect the left leg portion of the main body. That work? Flow on. Count that out. Off fluoro. Can you show the fluoral screen with the marker pigtail catheter?
Perfect.
And we'll use a 14-12.
Not a 12-12?
14.5 distal by 12 centimeters.
Sure. Now let's get the dilator to advance the sheath out. Let's get the dilator for the 12 French sheath, guys.
So we've also already measured the common iliac diameter. And so now we have the length measurement and the diameter measurement without having to do another angiogram to localize the hypogastric artery because we use the IVUS catheter.
This is too big. I need the 12 French sheath.
12 French dilator to this sheath.
Oh.
Now we have to advance the sheath into the contralateral graft limb so that there's no resistance when we advance the contralateral graft limb.
Okay, go to fluoroscopy, please. Okay, fluoro on. So now I'm advancing the dilator of the sheath, which is an obturator, so that we don't keep fluoring, so we don't snowplow into the artery. And I'm going to advance the sheath, and you can see it as it advances, all the way up into the entrance to the contralateral gate of the graft, which is right there. So now I'm inside the graft, off fluoro, and at this point it's safe to place our contralateral limb of our device through the sheath into the main body of the aortic endograft to complete the procedure.
Let's focus in on them prepping the graft. Basically, there's an inner stylet they have to pull out, and we have sterile gloves on to do it. Take out that yellow. And this is a PTFE graft with a nitinol stent skeleton. And Dr. Aka is going to advance up this graft for us and then deploy it.
Okay.
And the main thing we're concerned about is not to cover our hypergastric artery, which we have marked out on the screen using the IVUS catheter. So we'll put the last stent above that, what we said.
Okay, all right.
And we're going to use our 14 balloon.
So again, I have clean gloves on because the graft material is on the outside. And we will carefully insert it centimeter at a time up through the sheath. All right, fluoro.
Go to fluoro, please.
Okay, there we go. So you can see the stent graft going through about there. And then we'll pull back on the sheath so it can
Go to
deploy.
fluoro.
All right.
Off fluoro.
Okay, I'm going to stabilize the sheath and the graft. And Dr. Aka is going to deploy this graft. We're well above the hypogastric.
Go to fluoro.
Okay. Again, we'll loosen the sim pull, and we'll pull this ripcord-like device to deploy the graft. So, ready? Okay.
Okay, we will now hold the sheath. We'll now take out the device, and we're going to advance 2 balloons up to angioplasty the overlap regions of the grafts. And you know, we like to, when we inflate these balloons, we like to do it under hand inflation. That way we get the tactile feedback. And I think that has a less risk of rupturing the artery when you actually feel the resistance.
Go to fluoro. So you can see us advancing the balloons up.
And we're doing this simultaneously. Again, we want to limit our radiation dose as much as possible.
Off fluoro. Okay, fluoro on.
And this is just to really iron out the graft, make sure there's no wrinkles in it, and make sure there's good sealing of the overlap regions. Off fluoro. Oh, can you hold both sheaths for us?
Yep, sure.
Fluoro on.
Fluoro.
All right, we're going to balloon now.
All right.
Good. Off fluoro. We're going to take the pigtail catheter next.
Which side, sir? We only have 15 minutes, so we need to...
Fluoro on. We're going to balloon. We do not want to balloon outside the graft. So we're just at the edge of the graft. And it's just to really mold it out. We're not trying to... Off fluoro. Good. Now, believe it or not, that's basically the device inside the aneurysm. We're going to do our completion run.
Fluoro. Fluoro. So we're going to take the balloons out now.
Dave?
And we'll place a catheter.
So, Jeff, we're going to advance our catheter to do a final run. I think this is a good time for you to answer some questions.
Okay, let me just answer a question real quick, okay?
Oh, yeah,
Sure, go ahead.
Yeah, another question, just to repeat. If a patient has tortuous iliacs, what device do you choose and why?
You heard that, right? There's about 14 minutes left in the
It's unusual that will be the only challenge. Usually with these cases, that is the only challenge. But if it is the only problem that you have tortuous iliacs, we prefer to use the lower profile devices, which would essentially be the Gore or the Medtronic devices. However, I just want to say that is rarely the only problem involved, and that there are lots of factors that go into selecting these grafts, and we're really not trying to advocate one graft versus another. I'll just continue for now. Dr. Vo, are you ready yet?
You can go one more question, Dr. Hsu.
Keep coming back.
Down a little lower.
Back.
Okay.
Okay, good. Forward.
I have a question here. I think that's an interesting question, but it may take a while to answer. What is the risk of recurrence of the abdominal aortic aneurysm after the endoprosthesis? I think this is actually a really interesting question. I just lost my audio. I think this is a very interesting question because it kind of gets to the issue of what we're actually doing with the endovascular repair. To the person who sent this question, when we do these endovascular repairs, we actually don't remove the aneurysm.
Don't breathe,
so
don't move.
The question of recurrence is, I think should be rephrased. The aneurysm is still there. What we're essentially doing is we're depressurizing the aneurysm so that there is no more blood flow going through the aneurysm, hopefully. I think the question is really about endoleaks and continued pressurization of the sac after an endovascular repair, which theoretically would keep the patient at risk for rupture. So in order to answer the question, what we really need to do is we need to look at the rate of endoleak and rate of rupture. There's also another measure out there that was devised by the Stanford group called aneurysm-related death, and which is also another very good way to measure outcomes. But I think that's the real issue: is what is the rate of endoleak, what is the rate of sac expansion, and ultimately what is the rate of protection from eventual aneurysm rupture. I have a slide up here. It is the Gore excluder data, but essentially they were reporting a 10% endoleak rate, with most of those endoleaks being type 2 endoleaks and 2% being indeterminate. And they reported no post-procedure ruptures at 60 months. I think this is fairly representative of the data out there for the various graphs, and I think I hope gives the questioner some idea of how well this actually works in terms of protection from rupture. Okay, let's go back to Dr. Vo now, and Dr. Taylor and Dr. Aka.
Welcome back. What we have done is we've placed a main body, and then we placed a limb to go across the contralateral leg. And we've angioplasty, and we've done our completion run to see if there's any leaks. Let's go to the floral, and you can see the run here. Contrast is flowing through the graph. This is the initial run. Both renal arteries are open. Both hypergastric arteries are open. There's no contrast in the sac, so there's no type 1 or type 2 leaks. So we have a successful deployment of the Gore endoprosthesis aortic graft. What we're going to demonstrate now is how we close these percutaneous puncture sites. Let's focus in on the left groin.
So as you can see, we have a small incision here in the skin and the sheath there. We're going to remove the sheath, and then we're going to tie down the sutures. Gary's going to pull the sheath, and Dr. Vo is going to hold pressure. Go ahead, Gary. And I'm going to pull up on this suture and tie it down with the knot pusher. And then this locks the knot. We still have wire access in case this doesn't work and we have to close the artery the traditional way, which is by dissecting it out and making a larger incision. This is the second suture. Again, I'm going to cinch it down. Okay, relax, Dr. Vo. So as you can see, there's very little bleeding, and therefore we're going to take the wire out. Hold pressure. Wire out. Where is that?
Before we take it out, like Dr. Tiara mentioned, if there's bleeding right now, Majid, what would you do?
If there was a good amount of bleeding, arterial bleeding, we would put a third suture in, a third perclose suture.
And let's say that still has a lot of bleeding, what would you do?
Then what we would do is we'd put a sheath in and then go ahead and cut down and fix the artery open.
So we can always cut down under a very controlled fashion with the sheath in there. Okay. Pull the wire.
Pull the wire out. Okay. Go ahead and hold pressure. And now we do about 10 minutes of pressure holding on the left side, and that stops any oozing. Also, the patient has had heparin, which is a powerful blood thinner, and that needs time to wear off.
So we're going to do the main body side now.
Moisture tech, please.
I think we're perfectly on the schedule. This will take us about 5 minutes to close the main body. This was a 12 French sheath, and the main body was an 18 French sheath.
Okay, so Gary, go ahead and take the sheath out slowly, and Dr. Aka is going to hold pressure. Okay, good.
1, 2, 3.
Now we're going to tie. Let me in a little bit. Okay, hold pressure again.
So every time he passes that dilator, we're pushing the knot right onto the artery to secure the knot.
And now we lock the knot by pulling on the second string. And I tie them both down. Now we'll take the second suture. Hold pressure. And again, pull the knot down. Snap this. Thank you. Save that for later. Okay, knot pusher, and bring the suture down. Relax. Now, Dr. Ark is not holding any pressure, and the patient's not bleeding. So we'll go ahead and take the wire out. Okay, hold pressure. Okay. Again, lock the knot. Make sure that knot is cinched down real good. And now I'm going to cut both sutures.
How much contrast did we use?
And again, 15 minutes of pressure holding on this side. In the meantime, we should check the Doppler signals in our patient's feet and make sure he's getting good perfusion of his feet. So we'll do that next.
So we've done a completed endovascular aneurysm repair through bilateral femoral artery percutaneous access. And you can see there's pretty good hemostasis before even giving protamine. We've used 9 minutes of fluoro time, and I think we're able to minimize that by using the intravascular ultrasound. How much contrast did we use?
71 cc.
And we used 71 cc's of contrast, which is important to limit that amount because it can induce renal damage. So this is the left side. That's pretty good. Someone want to check the feet? You have a... yeah, Jeff, are there any questions? Or?
Let's get the here, and I'd like to get to as many of them as I can because we're running a little short on time.
We're basically done here.
Okay, why don't we go ahead and roll the animation real quick. Okay, this animation here really kind of graphically summarizes what we've just done. This is a picture of the aneurysm here, and this is the main body going up through a sheath being deployed. You can see one leg is already extended into the iliac limb. The other leg is a joint that's left open inside the aneurysm sac. This part is just going to demonstrate the features of the Gore endoprosthesis. Basically, it's a nitinol stent, sutureless with PTFE surface. Okay, continuing on, this open joint in the aneurysm then needs to be cannulated for placement of the contralateral limb. This part is just depicting the proximal fixation. The Gore graft does have barbs at the top that allow it to fixate to the neck. Shown here was just, they didn't show it that well. Basically, they had cannulated the contralateral limb and deployed the contralateral limb, and that's the final picture of the bifurcated graft.
Yes. Let's get 20.
Okay. All right. I have some questions here that I'd like to answer. One question was, when do these patients get discharged? Our routine is to observe these patients overnight in the hospital and discharge them in 24 hours. Occasionally we do have longer hospital stays, but approximately the majority of our patients are discharged in 24 hours. Another question here. Is it difficult to push the wire into the main body when you try to deploy the left leg? How do you deal with this problem? Okay, there are lots of different ways we do that. I think what the question is how do you deal with cannulating the contralateral limb if it's really difficult? What we do is we do a combination of things. We obviously use a combination of catheters and wires. I find it helpful oftentimes if it's difficult to introduce a long sheath as well as a catheter for extra support and torqueability. I think you get more maneuverability that way, especially if there's a significant occlusive disease in the iliac arteries. By angling the C-arm in various positions, you can get a better idea sometimes of where you are in relation to the opening. And we've also been using intravascular ultrasound to guide us in certain very difficult cases. Of course, there's always the bailout method of going up and over from the ipsilateral side and snaring the wire on the contralateral side. Although it's pretty rare that we have to do that, but it is definitely an option. At this point, I think I'd like to close. I'd like to thank everyone for tuning in. And I apologize if I wasn't able to get to all the questions. I'd like to thank our team in the operating room, thank you for listening to our webcast.
Are we back here? Okay.
Okay. As you can see, we have good hemostasis here through these small incisions, so we were successfully able to deploy the endograft and fix this aneurysm through a percutaneous approach. I want to thank everyone for joining us here in Fontana, and I want to thank all the team members here. And, well, I guess we'll say goodbye at this time.
Thank you. Excellent.
All right.
Okay. Camera off.
This has been an endovascular repair of an abdominal aortic aneurysm with the Gore Excluder AAA endoprosthesis, performed from Kaiser Foundation Hospital in Fontana, California. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed medical care.